Again, Dr. Mohanty explained before that the mitral valve is not simple to leaflet. There are many structures. So basically leaflets, the annulus, cardiotendinae, patellar muscles, the ventricular wall, all form a component of the mitral valve structure. So if you have pathology at any of these levels, they'll interfere with the valve function, resulting in pathology. Mitral valve is not a round structure. It's more like an elliptical or ovoid structure. It is thinnest in the posterior leaflet part, especially at the insertion site. The enlargement of mitral annulus occurs at the posterior leaflet part of the annulus. The mitral annulus is closely related to many important structures. I want to show that there are three components in the anterior leaflet. It's A1, A2, A3. The mirror image is again P1, P2, P3. Then you have anteroseptal commercial leaflet, posteromedial commercial leaflet. And you have left coronary sinus, non-coronary sinus in relation to the A1, A2, and the bundle of his in relation to the A3 and the P3. Then your circumflex artery is basically P1 and P2, and your coronary sinus in the P2 and the P3. They're important landmarks because they'll have an impact if you have a improperly implanted valve. Just to briefly indicate mitral valve replacement, mechanical valve could be mitral valve stenosis, rheumatic, lupus, calcific, congenital mitral stenosis, mitral valve insufficiency, failed prior mitral valve repairs, endocarditis, failed prosthetic valves, traumatic ruptures, the patellar muscle rupture from a myocardial infarction. Just one word I want to say about the lupus and renal dialysis patients. I've actually explanted 2 valves 3 months post-implant, tissue valves, in young people who have lupus. Similarly, it happens in real patients too. So I just had like 31-year-old woman. She's just got married, they put a tissue valve on her. 3 months she came back completely thrombosed, degenerated valves. So in my own mind, I don't know what valve is best with a lupus patient. That's why I put that to lupus, especially as one of the categories of concern. The perioperative management, appropriate monitoring lines, typical for any cardiac surgery patient. Pulmonary artery catheter, when appropriate, when I meant when you have low cardiac output, pulmonary hypertension, when you have multi-valve surgery, I always put a pulmonary artery catheter. The transesophageal echocardiography is standard of care, especially in Western countries. Whether one bypass or a complex reoperation, always have the TE as a gold standard for my management. In external defibrillation pads for any reoperations, a double lumen endotracheal tube, the planning for right thoracotomy or a minimally invasive approach. And this one thing I do in my practice, I always have a carbon dioxide insufflation in my operative field. We published a paper about 20 years ago showing the benefits of CO2 insufflation or flooding the field with the carbon dioxide. We minimize the risk of stroke, almost non-existent, and also we have a very low incidence of myocardial infarctions. The reason is carbon dioxide is 7 times heavier than the air, 20 times rapidly absorbed in the bloodstream compared to the air. So if any micro bubbles in the bloodstream, it rapidly dissolves, so you don't have any consequences from those air bubbles. How do you approach mitral valve? Well, I would say 90% time it is a median stenotomy, then followed by right thoracotomy. I have used left thoracotomy very infrequently. Partial hemistenotomy, again I use in women. Looking for cosmesis, the line of incision is well below the brow line, so it just makes it more appealing. It's a lower hemistenotomy. A minimally invasive approach with direct vision, video assisted, robotic assisted mitral valve surgery. So this is my least favorite. This is most commonly performed midline stenotomy incision, and a right thoracotomy with mini thoracotomy or a generous incision through both ends of space. And it's a lower hemistenotomy is another approach I used fairly frequently. The standard cannulation for the mitral valve is the aortic cannulation, bicaval cannulation preferred. I've also done it with a single cannula at times when I have a large left atrium. And I routinely use antegrade retrograde cardioplegia. I only have one shot of antegrade cardioplegia, but it could be a 30-minute operation or 3-hour operation. We always relied on the retrograde cardioplegia. I've done from 1990, since Gundry introduced it. I've not changed my practice. Again, this personal preference. Of course, systemic hypothermia is a key. Again, there are variations. Some people prefer to stay more than 30. Some people go to 28, 30. That's my preference. Aortic cross-clamping with initially antegrade followed by retrograde cardioplegia, 15-20 minutes, and local topical hypothermia with ice. Again, I use very sparingly. What are the alternate techniques? One is a right mini thoracotomy. I use this especially for women, young people, and also redos. My preferred approach. In this, we basically utilize a femoral vessel cannulation. There could be Seldinger technique or the open technique. Conventional aortic cross-clamping can be done. What I do, basically a small separate incision, the second interspace in the anterior axillary line, and then pass the cross-clamp. And I would say 90% of the time I can cross-clamp the aorta directly with this approach. We also have utilized the endo-aortic balloon occlusion. Sometimes the re-op is very hard to get cross-clamp across those, then have a beating heart or fibrillating heart. You need to be able to utilize any of these approaches because you may have something in your mind you want to go to one approach. The anatomy is not feasible, not conducive. You have to change your approach. That's why I'm emphasizing all these approaches, just to get an idea that there are alternative approaches available in your arena. So it's a conventional right thoracotomy, then followed by the femoral cannulation. Again, for cannulation purposes, I'll go tomorrow into this re-op and everything else, but I prefer to use left femoral, even the depicted here. The reason most people have the cardiac catheterization scar tissue in the right femoral, so I prefer to go on the left side. And the axial mitral valve is obtained through left atrial approach, the Waterston's or Sondergaard's groove, transeptal approach, forgive me, applicable in simultaneous mitral and tricuspid valve surgery, and the biatrial approach, which could be horizontal biatrial approach or superior biatrial approach. Most of you are familiar with this one, that is through the Waterston's groove, it's the intra-atrial groove. I would say 90% of people, that's how the surgery is performed all over the world. People may say they have more of minimally invasive approach, but in reality, if you look at the numbers across the world, it's a very small segment of the patients that have the minimally invasive approach. The other approaches are, this is they use Montefiore in New York City, which is a left atrial dome approach, superior approach, and I've used this biatrial septal transverse incision, and also a vertical transseptal incision. And this is a biatrial superior approach. In this, you almost always knock off the SA node artery, so you have a significant arrhythmia, so it's not my preferred approach. So what are the techniques for optimum exposure mitral valve? The bicaval cannulation, I think, offers the best unobstructed view. Pass tapes around the vena cava and pull the cava to the left side. Mobilize the cava. I do not always do it. The reason is, my suggestion is, have the tapes around the cava, expose the valve. The difficulty, then you dissect the cava. The reason is, you do an operation, that's not the first operation, that's not the last operation. They're going to come back for second or third operation. So if you make any incision in the body structure, it's going to leave scar tissue. So if you can leave an anatomy which is much more conducive for second operation, third operation, I like to do that. And that's why it's not carte blanche. Every patient gets the tapes around. Every patient gets dissection of the vena cava. I do not do that. Cannot dissect in the intra-atrial groove to the left side as far as the fossa valley. This I always do it. Sometimes I get right atrium. It's not a problem. You close small rent in the atrial septum. You can always circumvent the problem. I like to incise the pericardium to the right of the midline. That offers a better exposure by rotating the heart into the left chest. Again, dissect the adhesion on the left side of the heart for reoperation when it is safe. It has been always practiced, preached, that always dissect the left side of the heart. I do not do that. Because if you have mammary artery, the worst thing is you traumatize the mammary artery in the process of dissecting the adhesions, you're worse off. And I've seen people gotten to LVs, RVs with this process. That's why I always recommend, if you have good exposure, do not do anything more than what's necessary. Open the left atrium and carry the incision inferiorly and behind the inferior vena cava. That's always a very good way to have adequate exposure just by this simple maneuver. Other thing is place retractors. Spend some time to obtain maximum optimum exposure and study the anatomy. I've seen not only here, even in the US, people put the retractor, they want to start cutting the valve. Spend a little time. Look at the anatomy. Do you have adequate exposure or not? Is a valve disease repairable? What happened to subvalvular apparatus? And most people don't look at any of those things. They just go to the valve and cut the valve out. Spend some time. The key to successful surgery in any area is a good exposure of the valve, good understanding of the anatomy, and the variables come across. Because not every patient is same like other patient. Do not manipulate the left atrium and appendage before the aortic cross clamping for any unexpected thrombi in the left atrial chamber. The mitral valve exercise with the 2 millimeters away from the annulus, start in the middle of the anterior leaflet. Sometimes the plate traction suture can also put a clamp on it. Incision is carried to the left and to the right. Try to preserve the posterior leaflet if valve is not calcified. Even though I put a mechanical valve, I'll leave the posterior mitral leaflet if it is soft. If the leaflet is heavily calcified, cut the papillary muscle of the small valve tissue, which can reattach to the annulus. Care must be taken to not to cause LV obstruction by retaining too much of anterior leaflet. I had in my beginning of my career in 1984, the practice to leave all the valve tissues. I retained the entire anterior leaflet. I did 4 grafts on this patient, put a mitral valve prosthesis, and the second is not doing very well. But at the beginning of her echo, we didn't have an understanding. So we had an echocardiogram and found out she has severe LV obstruction. So third day, I took her back, took out the valve prosthesis, took out the anterior leaflet, and replaced the valve. It's my own personal experience. That's why I always say, do not leave too much of anterior mitral leaflet. They also retain excessive tissue that can hinder the proper valve function of mechanical valves. Avoid excessive traction on the valve or the papillary muscle while extending the tissue to prevent any annular avulsion or tear the left ventricular wall. The segments of A1 and A3 with the respective subvalvular apparatus, retain them, reattach to the respective commissures. So this way, you have basically entire anterior leaflet is free. You have only supported at the commissure levels. That basically opening the whole LV outflow without any hindrance. So there are 2 ways of putting the valve sutures. One is everting, another one is a non-everting. I'm sure probably most of you do everting sutures. When I say everting, basically the pledges are on the left atrial side. Suture goes from left atrium into the annulus, comes out of the LV, and then you pass sutures into the mitral valve sewing ring. So you're basically everting the annulus. The other way to do it is the place sutures from the LV through the annulus, right, and then to the prosthesis. So in everting sutures, the valve sits intra-annularly. In a supra-annular, the valve sits above the annulus. There's no tension, there's no eversion. So if you have a calcified mitral annulus, you're trying to put an everting sutures, there's a good chance you're going to have a tear in the annulus. In my practice, till today, I've not done everting sutures. That's how I was trained. But when I come here, 90% of valves are done this way. So I've learned something here, and also taught something to these people here. And again, I use interrupted pleasure sutures, horizontal mattress sutures. People have done the continuous monofilament suture, but I think the significant incidence of paravalvular leak with this approach. But again, a lot of experts is probably good in their hands. So this is basically everting sutures. The pleasures on the left atrial side, non-everting, the pleasures on the LV side. Am I in time? Okay. With the mechanical valves, the rim of retained leaflet tissue should be very minimal. Non-calcified post-leaflet can be retained if mitral annulus is large enough, can accommodate a large prosthesis. If you have a small annulus, if you retain the post-leaflet, you're going to have problem with the leaflet opening most of the times. As a rule, when for a 31 size valve, I can almost always retain a post-leaflet completely if it's not calcified. The large calcium mass of caudal tissue should be excised to give enough space for mechanical valve to function properly. If cards are thick or calcified, excise the cards and place Gore-Tex artificial cards. This I do when I have a poor LV function, because tip of the palpebral is always very fibrotic. I take 2 Gore-Tex sutures, tips of the palpebral muscles, put them at the commissural levels, and that does support, especially in poor LV functions. Again, non-eversion or supraannular placement of valve when you have a calcified posterior annulus. Again, place the sutures in the prosthesis at the intended position or orientation. It's a very simple concept. You put the sutures in the annulus and you put randomly into the prosthesis, sewing ring. Once you see the valve, try to rotate the valve. That's where you cause sometimes the disruption of the annulus or tear in the LV wall. Especially for youngsters, I think it's probably a good thing to, where you put the sutures, put the valve where you want to locate it. Minimize the rotation of the valve of tying the knots to prevent annular or LV tear. Use the manufactured devices to rotate the prosthetic valve. Why? If you use non-recommended instruments, clamps, you're going to break the strut or dislodge the leaflets. Till today, I have not seen in my practice. I have 70% practice all a valve surgery. And a significant in my practice, I still implant mechanical valves. I'll tell you the reason why. So far, I have not dislodged a leaflet because you have to pay attention to all those subtleties of this operation. The single disc valve is oriented with the disc mimicking the native anteromitral leaflet. What I say, when I say that the larger orifice of the single disc has to place posteriorly. It basically mimics the normal anterior leaflet motion. And with the bileaflet valves, whether it's St. Jude, Onyx valve, or any of these bileaflet valves, I put parallel to the aortic annulus, mimicking the normal mitral valve closure. Rupture of the LV wall is rare, but fatal complication happens from the too much traction on the annulus excising the mitral valve, implanting too large a valve or prosthesis, and removal of calcium on the posterior annulus can also cause the LV wall rupture. Had a couple of those, but able to repair it with a pericardial patch and put a valve. There are no catastrophes happened, but I recognize the tear. One of the things is the heart should not be tipped after putting the valve. Because once you put the mechanical valve, you lift the heart, that's a fixed point, and you're going to have a AV groove separation. And in my practice for the last 20 years, the way I de-air the heart, not through the apex, but the transeptally. I go right through the RV, across septum, into the LV. That's the most non-dependent part of the heart. Again, the perforation of the posterior wall of the ventricle from a prosthesis valve strut can happen, of course, more common with the solid-word valves. This is one of the valves I've explained about 37 years after implant. It was 18 years, 19 years when he had an operation, 1970, I think 77, 78. Just came back 3 months ago, he had a large aneurysm of the aortic aneurysm. 37 years, still functioning very well. There are no ball variants, there are no trauma to the struts. So just show to you that the mechanical valves, is properly taken care, could last for the life of the patient. This is one of my degenerated prosthetic valves, tissue valves. But again, don't take it as a gospel. So there's no ideal substitute prosthetic valve in the market. When possible, repair the native valve